This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Well, it's a pleasure to be here. Many of you probably don't know me. I'm an interventional radiologist invited back. I trained at UCSF some 25 years ago as a radiologist. So it's fun to be back, and I'm going to try and keep this in the spirit of a debate and be mean about it. So these are my disclosures, and I think the deck has been pretty well set, so I'm not going to spend a whole lot of time talking about the various treatment options for femoral popliteal disease, just to say that what I'm going to be concentrating on is longer lesions, lesions longer than most of the bare metal stent trials. And this has sort of been reviewed pretty well by the previous speakers. There's now 8 nitinol stent trials that have all had similar findings. Claudicators make up the vast majority of patients. In some of the trials, such as the Resilient trial, it was only claudicators. There were moderate to average lesion lengths of 6 to 11 centimeters, and there was a significant patency benefit over PTA alone. One of the interesting things I'll just point out, hearing what Pete and Chris was saying, is that if you look at the optimal PTA outcome group that didn't fail on the table, their loss of patency over time was as good or better as the patients that received stents in both the Zilver PTX and the Resilient trial. And so in-stent restenosis and that chronic irritation is a big deal, and I think anybody with a lesion over 10 centimeters, I have a great deal of concern over putting in full metal jacket, and most of us wouldn't want to do that. I think there's little supporting data. I think the Zilver PTX single-arm drug-eluting stent arm was sort of touched on, but I'll go into it briefly in more detail. This was a prospective, non-randomized, multinational study. It really was one of the largest studies to date. 787 patients, 900 lesions. The average lesion length was 10 centimeters, and it's a real-world population. They treated long lesions in stent restenosis, and they used overlapping stents. There was an oversight board and a data monitoring board, and they had duplex at a year, and then it was TLR rates after a year. I was on the steering committee of the original approval trial here in the US and a PAI on the Zilver PTX trial, and I'll just say, Chris, the reason that it was designed the way it was is because that's what the FDA required. There was no approved stent at the time that trial was designed, and it had to be randomized against angioplasty. So that makes it a little difficult to analyze the data because all of the patients that get randomized between bare metal stent and drug-eluting stent had failed angioplasty. So we were selecting the patients with worse outcomes right off the bat. So it's a little hard to compare, but this trial actually had some pretty compelling results. 86% primary patency at 12 months, 86% primary patency at 12 months in diabetics who have worse outcomes with bare metal stents, 77% in lesions greater than 15 centimeters long, and an 80% primary patency in the treatment of in-stent restenosis, all difficult patient populations, and pretty good data later on. We don't have any comparative data in long lesions, and so it's hard to draw conclusions. Okay, let's get on to stent grafts, my primary topic here. I've been doing this since day one, 11 years ago. I have a 100% clinical practice, so I have a lot of experience with this, and a lot of limbs have been reported, over 1,400 limbs. If you look at the non-heparin-coated stent graft literature and review it, it's about 1,300 limbs, average lesion length of 16 centimeters, substantially longer than other endovascular techniques. About 60% were chronic total occlusions, and approximately 20% of patients had ischemic limbs, which is pretty rare in all the other trials. And you can see the average patencies of 70% at 2 years and 60% at 4 years in those with long-term data, roughly approximate synthetic fempop bypass. So from a patency standpoint, stent grafts are already a reasonable alternative in long femoral popliteal lesions. But the heparin-coated results are different. So let's look at some bad results. The Vibrant trial was bare metal stents versus stent grafts. This was a prospective multi-center trial of greater than 8 centimeter long lesions. 20 centimeters was the average lesion length, high complexity lesions, much more realistic as to what we treat every day. dense calcifications in 55%. They had poor patency in both arms, no difference, 55% at a year and worse at 3 years, with actually good clinical outcomes, reasonably good in both groups. And it was difficult to analyze the clinical outcome because 21% of patients received stent grafts as a crossover for in-stent restenosis. So on an intention to treat basis, they didn't see much different. One of the things that isn't highlighted about this trial was actually the acute limb ischemia rate was higher in the bare metal stent group at a year relative to the stent graft group, 5% versus 2.5%. Did not reach statistical significance. But our real debate here is, are stent grafts safe? And this trial showed that they were at least as safe as bare metal stents in long lesions. The failure mode's quite different. Stent grafts fail due to edge stenosis. Bare metal stents fail due to diffuse in-stent restenosis. And one of the important things about this failure mode is this does not cause as much hemodynamic significance as this. So patients often are asymptomatic when they develop a high-grade edge stenosis. So you have to survey these patients like a graft to find them and fix them if you want to avoid thrombolytics and occlusions. Whereas with diffuse in-stent restenosis, these patients claudicate again, and we'll come back to you when they fail, often before they've occluded. All right, let's talk about the heparin-coated stent graft literature. There are now 2 trials on this that I think are illustrative and interesting. So this is a slightly different device. The top has been now laser cut and contoured, and it has heparin bound to the surface like the pro-patent graft, which stays around for months, if not years, and affects thrombosis. The Viper trial we just published in this year, I was the PI on this trial nationally. It's 11 centers, 119 patients, greater than 5 centimeter long lesions with no lesion length limit. The patient population was essentially identical to Vibrant, average lesion length of 19 centimeters, 60% task 2 C and D lesions, 61% moderate to severe calcification, and a small percentage of critical limb ischemia patients. If you look at the 1-year results, overall primary patency was 73%, secondary patency 92% at a year by duplex. There was no difference in primary patency by lesion length. So if you draw a cutoff at the median point of the trial for half the patients above and below, this was not statistically significantly different in longer lesions versus shorter lesions. The interesting thing about this trial is we've been noticing for a long time that sizing might be much more important than everybody gives it credit for. And early in the trial there were some failures that gave us some pause, and therefore an independent core laboratory was sort of initiated to look at all of the angiograms from the trial. These were 11 experienced investigators that were sizing by their sort of usual and customary approach. And when the core lab looked back on it, they found that the sizing the investigators came up with for vessel sizes was significantly higher than when they tried to calibrate and quantitate what the vessel size was. So investigators, even in this controlled collection of experienced investigators, were dramatically oversizing the device. And here's one of the 2 patients that developed rest pain or acute limb ischemia during the trial. Had a 27% oversizing relative to the proximal vessel with a 6 millimeter device placed into a 4.4 and 3 millimeter luminal vessel, a diseased vessel proximal and distal to the device. This was the only major adverse event at less than 30 days. If you look at this effect and actually looked at patients that were treated according to the IFU, according to the core lab, or were oversized by more than 20%, you can see that there was a statistically significant difference in patency of 18% at a year. So about half of the patients were not treated according to the IFU, according to the core lab. And when you make that correction and actually treat people according, carefully sizing the vessel, the patency results are dramatically better and approach venous bypass. But certainly industry, as we heard this morning, is spending $1 billion every couple of years at this point to try and improve patency by 18%. We actually can have some influence on that by the way we do things. What's the possible problem with this? Well, I think this has been talked about today. Overstretching the vessel, overdilating the vessel, injuring the vessel at the ends of the device leads to a problem. Here's an example, one case that we did, one of my partners. Looks like a reasonable case for a stent graft, except the vessels are relatively small. We do quantitative angiography, but they didn't calibrate the system, and they over-measured the lumen of the vessel. And you can see that this device, even though it's a small device, looks like it's oversized once it's in. 3 months later, it's occluded, And when I measured this and quantitated it, it's really a 3.5 millimeter vessel lumen with a 5 millimeter device, and that's not going to work. So here are the one-year results of the VIPER trial. 88% of patients were Rutherford Becker class 0 or 1 at a year, with a mean improvement over baseline of 2.4. ALI occurred in 2 patients, 1.6% of the patients overall. There were no major amputations, and the amputation-free survival was 96%. There was no 30-day mortality. 14 patients had revisions for surveillance-detected stenoses, and 50% were asymptomatic. So to do this and do this well, you have to survey your patients and make sure you fix asymptomatic stenoses. Only 4 patients went on to a bypass due to heparin stent-graft failure, and there was no adverse patency effect with diabetes, occlusions, or fewer runoff vessels, 1 versus 3, but not 0. And everybody with 0 runoff was excluded. This was significant and I think interesting. The patency was significantly worse in patients under 60. This has been shown in the vascular surgery literature as well with bypass, and I think more active patients cause more irritation and are maybe more prone to intimal hyperplasia the younger you are. Just comparing to population-based studies of bypass results, this is one from California, actually, 23,000 patients, femoral popliteal bypass. We don't know how many of these patients were CLI versus claudication. Operative mortality is about 4.3% at 30 days, and the limb salvage rates are less, so you can't really compare. But I think what you can say is it's hard to argue that stent grafts appear to have a lower morbidity. You can say they have a lower morbidity and mortality with similar clinical outcome. So, since this is a debate, Dr. Baitani and I may not agree. This is sort of how I view my wallet. This is how the government views my wallet. This is how my kids view my wallet. This is how I view my wallet. But I worked with John Porter and Greg Manette up at OHSU for 5 years, so they taught me to take no prisoners and be aggressive and dogmatic, and that's probably why most vascular surgeons like me. So I mean no offense while I win this debate. Poor UCSF stent grafts results. That's why we're here. That's why I'm here and what we're debating. So there are a number of single centers, not just the UCSF results, that have had poor results with stent grafts. And I want to go through this trial that was just published in the Journal of Vascular Surgery. So this was risk factors for failure after stent grafts, 87 limbs in 78 patients. And you can see this was a pretty tough patient population. 45% were task 2D lesions, 39% were for CLI, and 29% stent grafts were used as a secondary intervention on patients that had already failed some other intervention. We know those patients are going to be more prone to fail whatever you do. 9% of patients had no patent tibial runoff at the time of the procedure. So you're setting up for poor results, and the patency was worse, about the same as Vibrant, but not horrible, 57% by TLR at a year. And this is, you know, sort of what you'd expect. But despite the poor patency, there was no in-hospital mortality, there were no amputations at a year, and only 9% in-hospital morbidity, which included things like UTIs. This was the big deal that the authors were very concerned about: a 28% major adverse limb event, thrombolysis, bypass, or major amputation. Now this is kind of a new definition for evaluating endovascular procedures that was basically proposed by the Society of Vascular Surgery Working Group in an OPC paper that Dr. Conti was involved with, and it's a reasonable approach, but I think you have to realize that this was the major reason that they were concerned, and this has a lot to do with screening, and I'll go into that further. The authors raised concerns because they had a high failure rate and a need for lytics in a patient population of 55% claudicators, and I agree with that concern. But there were no amputations in a population of 39% CLI patients. That's a good thing. Thrombolysis was used in 17%, bypass in 11%, and there was a big concern about this ALI rate, a total of 9 limbs, okay? But this was substantially higher than other trials, especially VIPER and VIASTAR, which I will show you. But 4 of these limbs were in patients that were class 5 or 6 pre-procedure. So if they went back to being ischemic after the device occluded, I'm not surprised. 5 were in claudicators. 3 of these patients went on to a bypass. So 3 claudicators ended up with a bypass due to occlusion in this trial. The bypass rate in claudicators was low, especially if your alternative was a bypass in the entire patient population. which probably was, given the degree of difficulty of these patients. So let's look at these objective performance criteria for CLI. Now, this is not a CLI population, but in this trial it's 40% CLI. And these are the definitions: amputation-free survival, and a number of different sort of thresholds to be met. One of the things about this was that major adverse coronary event, including death, in the surgical standard of care trials that were used for the OPC was 6.2% at 30 days. And that wasn't set as one of the OPC standards. So if you reinterpret these results based on the OPC, I think that they met most of the OPC criteria that mattered. There was no in-hospital mortality, likely low 30-day mortality. The major adverse coronary event rate, including death, as I said, was 6.2% in the standard of care. They had a very low early morbidity and mortality. There were no major amputations in their trial. The OPC was 84%. The amputation-free survival was 83%. The OPC was 71%. So I look at this as the glass being half full, especially in a population of 39% CLI patients. It's not perfect. Yes, there were acute limb ischemias and claudicators, but I believe the low patency rate and major adverse limb event rate, it was very technique dependent. So let's go through that. There was no quantitative technique used to size the vessels. They dilated to the device size, not the vessel size. They didn't measure the vessels. So now you're potentially taking a 5mm device, putting it in a 3.5mm vessel and dilating it to 5mm, or a 6mm device for that matter. They likely caused a high incidence of edge stenosis, decreasing patency, and the patient follow-up was pretty poor. Only 63% of patients had any duplex follow-up at all. 8 of 10 patients treated with thrombolytics had edge stenosis that, if they were detected, would have prevented all of that thrombolytic therapy. So I think what we need to do is survey these patients. And again, I said 9% had no tibial runoff. Now, to be fair, a lot of us have had problems with 5mm devices. A lot of us have failed with 5mm devices. This is our data before the heparin-coated Stent-Graft device. And we had horrible early 5mm patency when we did this back in 2007. This was published. And this is part of what caused us to go back and start looking at sizing. And in fact, because of this, the Vibrant trial had no 5mm devices used. They were using 6mm devices based on the concept of surgery that 5mm conduits do worse, okay? But in fact, I don't think that's the problem. I think the problem is how we're sizing the devices relative to the vessel. So I think we made a mistake there. Because if you look at Viper, there was no difference in patency by device size. We're getting closer to sizing the devices correctly, and perhaps the heparin surface is helping with 5mm devices. But if you look at this, where they didn't use any 5mm devices in Vibrant, you know, there was a 16% higher patency, a 32% improvement in primary patency at the end of the 1-year window in the same patient population. So to just finish this, I think VIASTAR is the last trial I'll talk about, heparin stent grafts versus bare metal stents. This is a multi-center randomized trial of 114 patients, and the lessons learned from Viper were incorporated into this trial. This has been presented but not published by Lammer at VIASTAR, and basically it was 18 centimeter average lesion lengths. All lesions were greater than 10 centimeters in length in this trial. So we're talking about very long TASC B, C, and D lesions, 74% chronic total occlusions, at least one vessel, patent runoff, and Rutherford-Becker criteria of class of 2 to 5. If you look at the results, sort of here's what happened. Again, safety, serious adverse events, 1 ALI in each arm at a year. AEs were the same, bare metal stents versus stent grafts. And the Cs and Ds were approximately 50% in both groups. Here are the results by patency, dramatically better patency in the Viabon arm versus the bare metal stent arm. If you look at greater than 20 centimeter lesions, it was 73% versus 33%. If you look at the shorter lesions, it was actually 86% in the Viabon arm, and that was statistically significantly better. If you look at secondary patencies, it was higher. And if you look at freedom from TLR, it was not significantly different. ABIs were better, and this is something we don't talk about enough, that the patient outcome clinically is actually better. And occlusions versus stenoses, there were more occlusions in the Viabon arm, but not statistically significant at all, and a ton of stenoses over here. And really not a significant difference in bypass. The TASC-adjusted odds ratio of a patient treated with bare metal stent was 2.9 times more likely to lose patency than those treated with a heparin stent graft, and their walking was much better. So it's approaching above knee vein bypass at a year at least. So best practices, not just UCSF, but a lot of other trials have not always been used because we've learned a lot in the last few years. And I don't think this is UCSF's fault. I think this is data that was done before we learned all of this. We really want to shoot, not oversize the device. We want to shoot for 5%. And that really couldn't have been done in their trial. We want to post-dilate to the native landing zone, not the device size. We don't want a PTA outside the device as much as possible. We just want to get the device open. That wasn't done. We want to treat all of the disease, especially near the SFA origin, or it's going to fail. And I don't worry about occlusions because of the safety data that I've been showing you, and you've got to survey the patients and fix them when they fail. If you look at the risk of ALI, stent grafts versus bare metal stents, the US PMA, Vibrant, VIASTAR randomized trials all showed no difference. And the Viper trial and VIASTAR trials with a heparin stent graft had less than a 2% ALI rate. So major adverse event rates are clearly higher with surgery and atherectomy. If you look at the definitive LE trial, the major adverse event rate was 7.6% in the atherectomy arm, including vessel perforation and distal embolization. So it was pretty bad. And so this collateral occlusion thing to me is an urban myth. This is what I think happens when a bare metal stent or a stent graft goes down that causes acute limb ischemia. This is a patient I treated with a short little SFA occlusion with a nitinol stent for a failed angioplasty, and 5 months later came back with acute limb ischemia. Had a wide open SFA before I treated him. Okay? And what he did was he thrombosed this and for some reason occluded his whole SFA and embolized to his trifurcation. And those are the stent graft patients that I see that come back with acute ALI, is you're treating extensive disease. If it goes down and it embolizes, you've got acute limb ischemia. But that happens with bare metal stents when you're treating extensive disease as well. But do you end up with amputations? I don't think so. I think it's treatable and the patients do well. So we don't have any data versus drug-eluting stents. I think Zilver PTX is going to have a major role to play, but I'm not going to talk about that because I'm out of time. Cost-effective care is getting it right the first time. What can we control? Well, we can be more, we can treat with more objective treatment algorithms. We can improve outcomes and effectiveness by using quantitative angiography or some form of internal calibration or IVUS at the time we do stent grafts. And I think this affects nitinol stents as well. Our eyeball is really just not good enough. Some patients are clearly better treated with a bypass, a bare metal stent, or a drug-eluting stent, and I think we need to individualize the care. But if we do that, we could get some pretty good results. When are stent grafts the preferred treatment? I think they're the preferred treatment right now in long lesions greater than 15 centimeters, preferably in patients over 60, with landing zones of 4 to 4.5 millimeters in which we don't oversize it and we cover all of the disease, and you can get good results. So I would like to conclude that endovascular approaches have lower initial morbidity and mortality. That's pretty clear. It is very unusual for a patient to need an amputation after a Viabahn with heparin occludes who didn't have CLI pre-treatment. One-year patency rates are at least equal to synthetic bypass and approach venous bypass when patients are carefully selected and carefully treated. Randomized data shows significant benefit over bare metal stents in long lesions. Other endovascular techniques have a major role to play, especially drug-eluting stents and drug-eluting bioabsorbable stents in the future. Not all patients are a candidate for an endovascular approach. I clearly realize that, and venous bypass remains an excellent option, especially if conduit is available. One size did not fit all, but heparin stent grafts are clearly appropriate if we used with careful technique and correct position. So I end my debate. I win.
Thank you. Thank you for giving me the opportunity to defend our experience. I fortuitously put claudication in italics up here because I think we were kind of confounding the issue a little bit there, mixing in performance goals and critical limb ischemia, when really the issue here today is claudication, which, as we all know, has a relatively benign history, natural history in untreated disease for the majority of people outside of the diabetic patient. So remember that as we kind of work through our conclusion at the end here. No disclosures. And we've already heard a lot in terms of introduction about percutaneous endovascular interventions for lower extremity disease, the drug-eluting stents, the drug-coated balloons, et cetera. The key is each technique and each technology brings a unique set of advantages and disadvantages to the table, and we just have to be careful in how we select each one for each individual patient. As Dr. Saxon so eloquently mentioned, a more individualized, tailored approach. So the argument here today is that really the stent graft in SFA occlusive disease shouldn't be a first-line treatment for claudication. It's just that it should be correctly selected for the right patient. And so we'll try to sort out who that right patient is. So what are the advantages? I will concede every one of these points to Dr. Saxon. PTFE-covered stents have less ingrowth of cellular elements through the interstices of the stent, and so you get less in-stent stenosis. No question about it. He showed this picture. I think everybody has seen this. You get this in-stent stenosis in the bare metal stent and the focal stenosis in the stent graft. Now, obviously, not everybody gets the diffuse in-stent stenosis. If you look at the variety of trials out there that report different grading systems of in-stent stenosis, you can get focal stenosis just as you can in the Viabond, but I think this is a legitimate advantage of the stent graft. Aggressive angioplasty of a heavily calcified lesion, you get a lot of recoil, you're worried about a flow-limiting stenosis. Certainly, you can do that free of worry of rupture and extravasation. And I think unique to the Viabond, their nitinol support structure gives you less stent fracture. I think that's been shown repeatedly in a number of trials. There are reports of other people putting other stent grafts in the SFA, but I think everything that we're going to talk about today is about the Viabond since they have FDA approval for SFA indications. So this is, what I will not concede though is that the endoluminal bypass myth that the Viabond stent graft is the equivalent of a PTFE bypass in terms of outcomes, or possibly even, as Dr. Saxon was mentioning, a vein bypass. And I won't do that because actually of the exact thing that he mentioned, the collateral circulation. This is actually images from Gore about a case they have in some of their handouts, and it doesn't project very well, but they're showing you the pre and post treatment here, this SFA occlusion, and then treated with a Viabond. And even in some of the material, they showed these prominent collaterals end up getting covered by the stent graft, right? So why do I think that this is a myth, the endoluminal bypass myth? This is an angiogram of a bypass, right? So this is a PTFE bypass, the below-knee popliteal artery, and this is actually that exact same image that we saw moments earlier. When these bypasses go down, this is an end-to-side bypass. This is an end-to-end interposition graft. When this bypass occludes, this robustly arborized collateral network above the artery is not affected, right? The artery does not thrombose. The bypass graft thromboses. So when you're treating a patient with claudication who has abundant SFA to SFA and profundent to SFA collaterals, this doesn't go down. This claudicant ends up reverting back to claudication when this bypass graft goes down. When this goes down, it will thrombose until there's a prominent branch above or below, oftentimes the whole SFA. So this is, you're fundamentally changing the anatomy in the process of doing this treatment for this patient. And that, in theory, is why we see the late adverse events when these devices fail. And it's not a myth. I mean, we've published this. Dr. Saxon referred to it extensively in his presentation. But if we look at the collaterals that are covered on those angiograms where that data was generated from, actually a fair number of collaterals, both proximal and distal, are covered because the occlusions often occlude back to the level of collateral. Oftentimes, it's difficult to treat these without actually covering up the collaterals. So, Dr. Saxon showed a similar slide. Does it translate clinically? So we know what the advantages are, the putative disadvantage of each technology. What does it mean for the patient that you're treating on the table? This is a little more abbreviated. He showed all 1,400 patients, including the entire history of stent grafts, including the Hebomon trial in Europe. This is just the last 6 years of experience. There's a variety of publications out there, all of different flavors. So retrospective series, obviously you'll see Dr. Saxon's name on here a fair amount. Prospective single-arm studies, prospective randomized trials, randomized in this case to a bypass, a PTFE bypass, or in Dr. Saxon's case, randomized to balloon angioplasty. But the key trials, the Vibrant trial and the VIASTAR trial, the prospective trials, comparative effectiveness, looking at bare metal stents against the Viabonds, are not in the public domain. So these are yet to be published, and obviously we'll get some more information. The Vibrant trial, I think, is in the proof edit stage, and it's tough to go to a debate and tell people one thing without it actually being something that everybody can look up. So we'll trust what we can get from the device manufacturers. This is from the Gore speaker set, and basically primary patency isn't appreciably different between the bare null stents and the stent grafts at 1 year. So why do I even bring that up? Well, I bring it up because if you take the 10,000-foot view of the situation, these devices are probably more alike than they are disalike, probably more similar than they are dissimilar. So what you're looking at, in theory, are modest incremental advantages in patency, reintervention rate, secondary patency if using one device or another at 1 year. What we're trying to do is find a subgroup of patients where you can really extend that advantage, and that was what really, I think, when I look at Dr. Sachs's data, that's what I really glean out of it, that you can't just routinely use this technology. You have to find the right patient where it may be beneficial. Hence, the focus on the patient with a particularly long lesion. Because, 70 to 80% reintervention, primary patency rate, they're not that different. They're more alike than they're dissimilar. So it's really not about patency, right? It's not the only thing that we consider when we choose to do the intervention for these patients. It's really choosing the best treatment. And that depends on what outcome you value, right? Your estimation of what will happen if you fail, the resource utilization. To sum it all down, it's the risk-benefit ratio for the patient, right? And the risks are not just limited to the risks in the periprocedural period, it's the risks long-term of implanting the device, what happens 1, 2, or 3 years down the road. The majority of the data out there is really midterm data, 1 or 2 year results. Vibrant is fantastic because it's 3-year results. What I will say in terms of the major adverse events in Vibrant, I don't believe acute limb ischemia was a predetermined endpoint. So again, it's not published, it's hard to know how to interpret that, but you really need to understand the risks of intervention before you can accurately decide what is the best treatment for that particular lesion. So we set out to help answer that question. That was the whole point of looking at our experience. What are the risks of failure? Again, are there patient or anatomic specific factors that will help predict who is going to fail with the stent graft treatment? And then, more importantly, what are the clinical presentations of failure? Remember, especially in a claudication, are they coming back as a claudication, or are they coming back with critical limb ischemia or acute limb ischemia? And so the first of these studies that we reported, published by Dr. Johnston, along with the rest of the group here, was our single institution retrospective series looking at 87 patients. And 2005 to 2010, so this was an older generation Viabahn for a lot of the patients, not the heparinized coated surface and certainly not the scalp surface. And a lot of his criticisms about the device sizing and selection, I think while it may or may not be valid, again, it was only the Viper trial that has demonstrated this. Even in the Vibrant trial, as he mentioned, device sizing may not have been appropriate. That was how the world practiced at the time. So, and he was correct in that prior endovascular treatments were present in 30% of patients. So when we were looking at the adverse events, it was really by treatment received. So patients that had a previous experimental stent with in-stent stenosis that were treated with a Viabahn, that came back with a complication. It's hard to know what caused it, but you obviously have to consider that the last device placed was at least partially responsible. The endpoints we looked at were both the clinical presentation of failure and also the nature of the reinterventions. And we analyzed the data in both a univariate and multivariate fashion to be able to help identify those risk factors. He mentioned some of our data. Again, he said these were particularly tough patients, but I would argue that this is actually a real world patient population. These are probably people that you see in your clinic, TASC lesions, CTOs, some of our collateral data there. This tibial collateral coverage, I'd take not the 9% with no tibial runoff, I don't think is accurate, actually. I think these are tibial runoff scores that the SVS has published as guidelines for reporting tibial runoff. We don't do SFA interventions to isolated popliteal segments. So you can have a 50% stenosis and it would still give you in one tibial runoff, and it would still give you what appears to be the worst possible score. So all these patients actually did in fact have tibial runoff. I don't think that's why we had those results. And this is what we saw in our real world practice at 1 year, a 50% primary patency rate. This actually is not that different than what is published in the Vibrant trial. Their 1 year primary patency rate was also very close to that. What they like to highlight is really the secondary patency, et cetera. But what's interesting isn't just the reintervention rate, it's really what's going on with the rate of thrombolysis and the rate of major adverse limb events. Also, this definition, which was previously mentioned, derived from the objection performance guidelines through the SVS, is different than what Viper defines as a major adverse event. This is any bypass, any occlusion, any thrombolysis, any amputation. I believe occlusions, et cetera, are not considered adverse events in the Viper trial. Maybe Dr. Sexton can clarify that. And obviously the risks, it's not just the risk, but the costs of the reintervention were very significant for the rehospitalization, thrombolysis, and reintervention. Now, seeing that data, the first question we had is, well, how does this compare to our experience with bare metal stents? And can we make this comparison a little more cleaner? So we looked to restudy this in a more contemporary patient population. We chose to study patients from 2008 onward because that's when we introduced the heparin bonded stent graft in our practice. And so we looked at only patients that had the heparin bonded ViaBond implanted, and we eliminated anybody that had a previous reintervention. So this was first-time interventions for infrainguinal vascular disease. And we had 134 patients that kind of met this inclusion and exclusion criteria. And just looking at the patient demographics and characteristics preoperatively, pre-procedurally, it wasn't a complete fair comparison in that there were more end-stage renal disease and critical limb ischemia in the bare metal stent group, and more TAST and CTOs in the Stent-Graft group. But other than that, the remainder of the comparison between the two groups was equivalent. And the Stent-Graft, ViaBond, actually did outperform the bare metal stent at 1 year, event-free rate of 75% versus 64%. But this is not the whole picture. It's not just about primary patency at 1 year. We noticed a real major adverse limb event. It wasn't statistically significantly different because in our series we had 4 major amputations, none in the ViaBond group, but these 4 amputations were in people that had amputations within 2 or 3 months of their intervention despite having patent stents. So these were people that were undergoing aggressive limb salvage with endovascular techniques that probably should have gotten a primary amputation. What's really striking is the rate of thrombolysis necessary for the Stent-Graft group. Why is that? Well, one reason was the high rate of acute limb ischemia that we had. Again, this was different than this is a different cohort of patients that what we had published and what Dr. Saxton mentioned with the 11% or 9% acute limb ischemia rate. This is a more contemporary patient population, and again, we noticed 9 acute limb ischemia events in the Stent-Graft group, 0 acute limb ischemia events in the bare metal stent group. This is in part a function of long follow-up as well. So whereas it's mostly short-term, mid-term follow-up in a lot of the device-sponsored trials, the average follow-up in this group was approximately 500 days, and we had follow-up up to 900 days. So if you follow these long enough, eventually you will start seeing acute limb ischemia. And I think more ominously, it was that it was difficult for us to predict who would develop acute limb ischemia. If you look at all 9 events and their task classification, there were 3 patients with task A lesions that went on to develop acute limb ischemia. Nobody suffered an amputation. Everybody was salvaged with either bypass and thrombolysis, or bypass, thrombolysis, and fasciotomy. But these are real risks to the intervention. When we looked at it in multivariable modeling to identify what the risk factors were for acute limb ischemia, really only 2 things came out. It was device selection, whether bare metal stent or stent graft was used, bare metal stent was protective, or the presence of a chronic total occlusion. Since we had more chronic total occlusions that were treated with stent grafts, obviously these tend to co-localize in terms of the analysis of the data. So back to the topic at hand. How do the claudicants fare? Here's our claudicant subgroup analysis. We basically had a recapitulation of the results when we look only at the claudicants. The device selection was a predictive factor in determining who went on to produce acute limb ischemia. These are 76 claudicants in this cohort of 104 limbs. And this is really, I think, the most key point, the net change in the Rutherford class. So of the 74 people that were treated with bare metal stents, 5 people came back on device failure, device occlusion, with either critical limb ischemia. Nobody actually could develop acute limb ischemia, so a 9% progression rate due to device failure, 17% in the stent graft group. That's double the rate that we saw in bare metal stents. Though this did not meet the threshold for significance, I suspect if we studied more patients for a longer period of time, this would actually be a true finding. And so why would that be? I mean, it's hard to look back and think about the effect of the stent graft really functioning as an interposition graft and thrombosing and losing all those collaterals, that is not having a profound negative effect on the lower extremity circulation. So to summarize our experience, again, it's a retrospective analysis. There's obvious selection bias. And yes, there was the rate of reintervention lower with the stent graft group. It was marginally better with the Viabahn. But the types of reinterventions were more severe. So they weren't necessarily benign reinterventions. Higher rate of thrombolysis, which obviously has real risks to the patient. And 12% of the people that had stent grafts placed followed in our group ultimately developed acute limb ischemia. 12%, which begs the question, is that really worse than the natural history of the disease in the first place? Failure of either device does not necessarily revert the limb back to claudication, but it seems appreciably worse with stent grafts than bare metal stents. So, to conclude, the con side of using stent grafts in SFA, are there technical advantages? Absolutely. When do I think we should not use the Viabahn? We shouldn't use it routinely as first-line treatment in SFA disease and claudicants. When should you use the Vialon? Obviously, if perforation to salvage that, a recalcitrant lesion that needs an aggressive angioplasty. And then I put this long segment lesion here in italics with a question mark because honestly, I do not know. And while this speaker set for the VIASTAR trial suggests that, I think until we have VIASTAR trial data, we don't know. And why VIASTAR trial, they actually have a very high rate of test CND lesions and a very high rate of CTO. So I think this last question here, long segment, I think is also unanswered, but hopefully we'll have that answer soon. Thank you for your attention, and I think we'll take questions here.